So I'll be discussing about the ways how we monitor glucose in the hospital setting. And when these slides were made earlier, whatever we have discussed so far, at that time, the emphasis was mostly on the point of care glucose testing, and CGM was not into that much of play at that point of time. But now that in hospital, CGM is being increasingly used, especially after the COVID, so there will be some discussion regarding that also. So in hospital blood glucose monitoring, basically we are measuring blood glucose. As Dr. Sunil mentioned, measuring POCT or point of care glucose testing is a fifth vital sign, because every patient who gets admitted to the hospital needs to get their glucose checked. So just as we are measuring the other parameters, a blood glucose needs to be also checked. Now, it could be in the ward or the non-critical setting where the samples can be sent to the central lab, or you can use a glucose meter to do a point of care testing, or it could be through use of venous or arterial blood gas. In the critical care setting, usually it is done by the venous or arterial blood glucose, or point of care is also there, but then only few glucose meters are approved for use in the critical care setting. So remember that the glucose meter that is commonly used, not all of it is approved because to be used in the critical care setting. And then obviously there are multiple CGM devices. In India, we don't have that many at present. We are using mainly the Freestyle Libri and the Guardian Connect for this. So our results will basically differ from sample type to sample type. It will also depend on what assay we are basically using to measure that. And then there will be a difference between what results we get from the lab and what results we are getting from our point of care device. So the advantages here is that obviously you can use multiple specimens. It requires a very small volume, so you don't have to do a vinipuncture. And it reduces the therapeutic turnaround time because you can get the results in seconds. And that allows us to monitor the patient serially, especially in the ICU setting. When the person is on ICU infusion, we can measure glucose every 30 minutes or 1 hour, and we can get the results within seconds. Now, the limitation is that it will just give you a snapshot of the glycemic control. It's not going to tell us about any hypoglycemia that has happened, or periods of hyperglycemia can also be missed. So the challenges associated with the bedside glucose meter, we can divide it into three mainly. One is that pre-analytical, that is happening before the sample gets collected. The analytical, basically when the sample is being tested, and the post-analytical, that once the sample is processed and the data is fed. So mostly it is the pre-analytical errors, and it could be, and remember that it is mainly environmental and technique dependent. For example, in a glucose meter, if the strips are exposed, then it is a problem. Many meters which are like glucose oxidase based will give you a false result. If the technique is not, if the fingers have not been cleaned properly, then you can get a falsely high reading. And then you have analytical measures which basically depend on what assay is being used. Here, basically the GDH methods are more sensitive to these fallacies. Then presence of certain drugs which are commonly used in the inpatient setting, like paracetamol or vitamin C, can affect the results. And then in the critical care setting, the alteration in the pH, hematocrit, and oxygenation, all these factors will basically affect the values. In the post-analytical, it's mainly whether you measured the glucose values. It was maybe around the 19 or 20, and it was like wrongly entered as 190. Then it can also be because of any verbal communication, basically. So mainly the pre-analytical errors can be, you can basically reduce it through calibration. You can reduce it by using individually wrapped strips. Some companies do have those. Then usually the barcoding can also help, so that the wrong patient ID is not created. So you only enter the values which are there. So there are some glucometers which will wirelessly transmit the data to the central server. Now, the other thing is the endogenous interferences like hematocrit, hypotension, electrolytes, PO2. All these are mainly come into play in the critical care setting. And then exogenous like the ascorbic acid, acetaminophen, they come into picture in a routine ward also where these are commonly used. So to just give you an example, a simple increase in hematocrit will increase the, if the hematocrit is increased, the values will be low. If the hematocrit is decreased, the values will be high. Then in presence of, say, hypothermia, the values can be slightly increased. Then vitamin C can increase both in the glucose oxidase as well as dehydrogenase method. And in case of acetaminophen, it will again increase or decrease. The thing is that all these things will come into picture when you actually have to think about it, because all the different glucose meters will have their product insert. So you'll have to individually go through them to exactly find out what is the range where they are safe and at what range they are unsafe. Then patients who are on peritoneal dialysis, their icodextrin and maltose is being used, and there are reports of fatal hypoglycemia because the glucose meter falsely recorded high readings and they were given insulin infusion, leading to fatal hypoglycemia and death, actually. So all these things have to be kept into mind. So we discussed that we need good glycemic control, but are we measuring it correctly? And if we are measuring it correctly, what is the impact? Because as you know, in trying to achieve a good glycemic control, if there is a fatal hypoglycemia, it will be an adverse event. So we had seen in the earlier slides about the various trials which have been done in the critical and the non-critical setting. So till 2010, there was not much emphasis on the type of glucose meter being used. After that, once the nice sugar came, then basically one of the fallacies which was basically being discussed was it was a multi-centric study, but those centers used whatever means was available to them for glucose monitoring, right? So it was not a specified method. So that could also have led to some variation in the results. So after that, the FDA approved basically the stat strip glucose meter for use in critically ill patient. That too, only venous, arterial, and heel stick blood sampling was allowed. It did not allow capillary glucose testing. But now, even that is also being allowed. So I'll skip this. Yeah. So for glucose meter performance, it is important that currently, if 95% of the total measurements with the POCT glucose meter should agree within plus minus 12 of the lab analyzed value, which is if it is the blood sugars are less than 75, or it should be within 12% of the lab analyzer value if the sugars are more than 75. It is important that we define the gold standard. So what is the gold standard? So gold standard obviously would be something like an IDMS where it is an isotope basically dilution method. It's not available. The other is that your central lab basically does it through the hexokinase method. So that is something that can be used. So then just a meta-analysis or review of the accuracy of blood glucose measurements. It just mentions that the capillary glucose testing will be inaccurate, especially in the younger age, where there's a low perfusion index, vasopressor use, edema, and it is not associated with albumin, lactate, and pH hematocrit. So all these things are commonly seen in patients in the critical care setting. So these are the various basically brands of glucometers which are available along with the methodology. And you can see in the stat strip, there is no hematocrit range. So it adjusts for the hematocrit and it gives you the correct value. So these are different, not all of them are available in India. We have the iStat here, Abbott iStat is available, and the stat strip is available in India. So as I mentioned, the icodextrin in the peritoneal dialysis led to severe hypoglycemia and death. Then the point of care testing where the hematocrit and ascorbic acid has also led to falsely increased values. So hematocrit, as I mentioned, a high hematocrit will lead to a falsely low value, and a low hematocrit will lead to a falsely high value. So there are methods to address the hematocrit effect. For example, the stat strip has another electrode that basically measures the hematocrit directly, and it adjusts. The other thing is that some of them which are used in the ICU, basically like a hemocube, will lyse these cells. Because when we are basically puncturing or you are using the finger prick, you are using a whole blood sample where the lysis has already taken place. So all these glucose meters will work only with a whole blood, which then gives you a plasma equivalent value. They are not going to work on serum. So the thing is that now that we know that at certain situation, we cannot use these glucose meters effectively. So there is one criteria called BRAVE criteria, that if your blood pressure is less than 80/50, or the capillary refill time is more than 3 seconds, if there is acidosis, like ketoacidosis or hyperosmolar coma, if there is a use of vasopressors like which is exceeding for dopamine more than 5, or if epinephrine more than 0.6 micrograms per kg per minute, or if there is edema at collection site, then one should avoid using the glucose meters. So because you'll always get false results, and starting insulin infusion or giving a dose of insulin in such a situation can be erroneous. So always either confirm through the central lab or use some other methods, maybe like a stat strip or iStat method for measuring the glucose values. So to conclude from the POC glucose testing, that it is the standard of care to assess glycemic control currently and to adjust the therapy, but it fails to provide you the 24-hour glycemic profile assessment. And it does not detect any asymptomatic or nocturnal hypoglycemia until unless it is tested for the same. And it is labor intensive, prone to errors, and there are mismatched measurements, especially in certain situations. So what solution do we have here? So one is that we can use the continuous glucose monitoring system. So it can be of various types, like invasive, like intravascular venous or arterial being used. Now not that popular because our sensor technology has improved, and even with transdermal and subcutaneous, we are able to get reliable results. And then sampling frequency can range from 1 minute to around 15 minutes. So one is a real time, which will give you continuous data, and it will transmit the glucose data in real time. One is intermittently scanned, like you have the freestyle Libri where you scan and you will get the result on the screen. And there is one integrated way where this device basically will communicate to the automated insulin delivery system. For example, if the patient is wearing a insulin pump, or if you have a automated insulin delivery system like a glucocommander, then that will be utilized here. So CGM metrics basically is 3 or 4 things. One is the time in range, which should be kept above 70%. And then time below range, that is to avoid hypoglycemia, less than 54 should be less than 1%, and time above range, that is more than 180, we have to target it to be less than 25%. So as we have seen in the previous talk also, that basal bolus is the way to go in the inpatient setting. So whether we can utilize the point of care, the continuous glucose monitoring system in this setting, we'll see in the next few slides. So the timeline, as I mentioned before COVID, there were small studies. It is just after the COVID struck that people became more interested in this technology because one, it allowed us to monitor remotely, and which was the need of the hour at that time. And so in the last 2 years, there has been numerous publications regarding this. So these are the CGM systems that is available. So you see, whatever was basically applicable to the glucose meter is applicable here also in terms of their interference. And especially salicylic acid, ascorbic acid, and then in some situations, mannitol and hydroxyurea. So, so here what we are using is mainly the freestyle Libri. So only freestyle Libri is available. Libri 2 is not yet launched in India. So some of them are factory calibrated. So you need not kind of measure the glucose meter with the point of care in the hospital. There is a warm-up time. It will not give you readings immediately. You have to wait from 30 minutes to 2 hours for a proper assessment. So the various trials have been done. So I'll just mention. So in critically ill, the meta-analysis has showed that using CGM, mortality was reduced. Most importantly, hypoglycemia incidence was reduced. But overall, the time in below or above target glucose range remained the same. So hypoglycemia avoidance would be the key here. Then limitations would increase that if you're using intravascular, then there is a risk of infection, thrombus formation, then cost, and then the same interference that we saw in the glucose meters would come into picture here. In case of the, I'll show you this one, the basically non-critical setting, that is in the ward setting, there are various studies that have showed that basically, for example, in this study, the Dexcom G6, the MARD, which is basically used to measure the efficacy of a CGM, was less than 10. So if you are able to achieve that kind of control, then that means you can safely use that in the inpatient setting. So the challenges is at this point of time, there is no regulatory approval. There is then obviously these interferences will be there. So what will be the impact in case of hypotension, hypothermia? If the patient is shifted for procedures, X-rays, we don't know what will be the impact. And then overall, the best thing is that one is we have found is that hypoglycemia incidence and identification of hypoglycemia has improved. Overall, the hypoglycemia has improved, but overall the glycemic control has remained the same. Okay. So to conclude, this will offer a basically digital care. It will allow us to intelligently modify the pharmacotherapy, but it will require an ongoing validation. So that is important. So if you're using CGM, do use a point of care glucometer also. That is a hybrid mode